Welcome to Teaching Service Hospital Rounds. Today we are covering the management of inflammatory bowel disease. This is the therapy video. The two disease videos told you how to recognize ulcerative colitis and Crohn disease. This one tells you what to do about them. There is one framework underneath all of it. Induce remission first, then maintain it. And the drug that induces is often not the drug that maintains. We will work through the evaluation you complete before treating, then the therapy ladder for each disease, then surgery and cancer surveillance. There are real doses in this video, so keep a pen nearby. Every dose quoted here comes straight from the source table. None of it is from memory. We are going to use the same two patients from the previous videos. The first is our 26-year-old woman with left-sided ulcerative colitis, 6 to 8 bloody stools a day, moderately to severely active. The second is our 23-year-old man with ileocolonic Crohn disease, and importantly, he has perianal involvement, moderately active. Both of them now have a firm diagnosis. Neither of them has a treatment plan yet. That is exactly where this video starts, and we will come back to both of them at the end. Both are treatment naive, so we get to choose from the whole ladder. Here's what to take away. First, complete the initial evaluation before you treat. Know the laboratory panel. Exclude the diagnoses that mimic inflammatory bowel disease, and rule out infection before immunosuppression. Second, state the two goals of treatment, and understand what mucosal healing means. Third, match therapy to severity in both ulcerative colitis and Crohn disease, and be able to dose steroids, thiopurines, and methotrexate. Fourth, name the biologic classes by mechanism. And fifth, state the surgical indications and apply the cancer surveillance protocol. This video deliberately stops at therapy. The diagnosis was covered elsewhere. Start with the initial evaluation, a history and physical examination. And you are deliberately checking two things: the intestinal manifestations and the extraintestinal manifestations. Then the diagnostic studies we covered in the disease videos. Here is the emphasis. The extraintestinal examination is part of an inflammatory bowel disease assessment, not an afterthought at the end of the visit. Look at the skin, the eyes, the joints, and check the liver panel. A patient whose only complaint is diarrhea may have uveitis you never asked about. And document what you found. The extraintestinal baseline matters when you judge response later. Now the laboratory panel. Consider a complete blood count with differential liver function tests, iron studies, vitamin B12, folate, vitamin D, erythrocyte sedimentation rate, C-reactive protein, and fecal calprotectin. Notice why the vitamins are on that list. They are not screening filler. Inflammatory bowel disease malabsorbs, particularly when the terminal ileum is involved. So B12, folate, and vitamin D deficiencies are expected findings rather than incidental ones. The liver panel is there to catch primary sclerosing cholangitis. Fecal calprotectin is the one that tracks mucosal inflammation over time. Before you commit to a diagnosis of inflammatory bowel disease, exclude the conditions that imitate it. Infectious causes, and especially tuberculosis, ischemic colitis, intestinal lymphoma, colorectal cancer, irritable bowel syndrome, vasculitis, Behçet disease, celiac disease, and small intestinal bacterial overgrowth. Every one of those can present with chronic diarrhea and abdominal pain, and several of them get considerably worse if you treat them with immunosuppression. Intestinal tuberculosis in particular can be almost indistinguishable from Crohn disease on imaging. So take a travel and exposure history before you reach for a biologic. Now a rule with real consequences. Rule out infection before you treat with immunosuppressants and biologics, specifically tuberculosis, hepatitis B, cytomegalovirus, and ova and parasites. The reason is direct. Anti-tumor necrosis factor therapy reactivates latent tuberculosis, and it reactivates viral hepatitis. There is one honest caveat. Not every acutely hospitalized patient with inflammatory bowel disease can wait for a full infectious workup before treatment. But that is a considered exception in a sick inpatient, not a shortcut in clinic. Screening is cheap. Reactivated tuberculosis on a biologic is not. There are exactly two goals in inflammatory bowel disease therapy. The first is to induce remission of the acute flare. Get the patient out of active disease as quickly and as safely as you can. The second is to maintain that remission. Keep them out of it. And here is the point residents most often miss. A different drug is frequently used for maintenance than for induction. Steroids are the clearest example. They induce beautifully, and they maintain terribly. So whenever you start an induction agent, ask immediately what will hold the remission afterwards. Write the maintenance plan into the same note as the induction order. Underneath both goals sits a more specific target. Mucosal healing is the primary goal. Not symptom resolution, mucosal healing. Those are not the same thing, and the difference matters. A patient can feel completely well while their mucosa remains actively inflamed, and that ongoing inflammation is what drives strictures, dysplasia, and eventually cancer. It is doing damage the patient cannot feel. This is exactly why we re-endoscope these patients, rather than simply trusting a symptom diary. Feeling better is necessary. It is not sufficient. Mucosal healing also predicts fewer hospitalizations and fewer operations. There are two broad strategies. Step-up therapy starts with the least toxic agent and escalates through the latter only as the patient fails each rung. Its advantage is that low-risk patients never get exposed to strong drugs they did not need. Top-down therapy does the opposite. Start with potent therapy, gain control, then de-escalate. Its advantage is speed in a patient heading toward complications. And there is a specific instruction here. Consider an early biologic if the disease is severe. Do not walk a severely ill patient slowly up the entire ladder. In practice, most patients get a hybrid. The strategy names describe intent more than protocol. Here is the whole ulcerative colitis ladder on one slide. Mild disease. Rectal mesalamine or glucocorticoids as a suppository or enema. Mild to moderate, oral 5-ASA or MMX budesonide. Moderate to severe, oral prednisone at 40 to 60 milligrams. Azathioprine or 6-mercaptopurine at 0.5 to 1 milligram per kilogram. And anti-tumor necrosis factor therapy. Severe or refractory. Intravenous steroids, cyclosporine, anti-tumor necrosis factor, and the newer classes. We will now take those 4 rungs, one at a time. Notice how the ladder tracks toxicity. Each rung buys potency and costs safety. Start at the bottom of the ladder. For mild ulcerative colitis, the answer is topical, rectal mesalamine, or glucocorticoids given as a suppository or an enema. Think about why that works so well here. Ulcerative colitis always starts at the rectum. So in mild distal disease, the inflamed mucosa is within reach of a suppository. You deliver drug directly onto the inflamed surface, and systemic exposure stays low, which means you avoid systemic steroid effects entirely. A patient with proctitis often needs nothing more than this. Enema reaches higher than a suppository. Match the delivery to the extent of disease. Step up to mild to moderate disease. Oral 5-aminosalicylic acid, 5-ASA, comes in several formulations. Sulfasalazine, mesalamine, ulsalazine, and balsalazide. You choose the formulation based on where the disease sits, because they release drug at different points along the bowel. And here is a genuinely useful property. 5-ASA is used for both induction and maintenance of remission. The same drug does both jobs. Complications to counsel on: pancreatitis, abdominal pain, and diarrhea. Sulfasalazine additionally requires folate supplementation. It interferes with folate absorption. The other option at mild to moderate is MMX budesonide. This isoryl budesonide formulated to be released throughout the colon, and it is used for a flare. What makes it attractive is its pharmacokinetics. Budesonide undergoes extensive first-pass metabolism in the liver, so most of what is absorbed is cleared before it reaches the systemic circulation. That reduces the systemic adverse effects of a steroid substantially. Think of it as a steroid that largely stays where the disease is. You get local potency without the full systemic price. It is a flare drug, not something to leave a patient on indefinitely. Now moderate to severe disease. Oral prednisone at 40 to 60 milligrams, with a taper over several weeks. And its job is to induce remission. Say that clearly to yourself. Induce. Prednisone is not a maintenance drug in inflammatory bowel disease. Long-term steroids cause bone loss, diabetes, cataracts, and infection, and they do not keep the mucosa healed. So plan the exit at the moment you write the prescription. Taper over weeks rather than days, and have the maintenance agent already chosen before the taper begins. Add calcium and vitamin D, and think about bone protection for repeated courses. For maintenance in moderate to severe disease, we reach for a thiopurine, azathioprine, or 6-mercaptopurine, dosed at 0.5 to 1 milligram per kilogram and up titrated over weeks. Note 2 things about that. First, the indication. This is for maintenance of remission. Second, the timing. Thiopurines are slow. They take weeks to months to reach full effect. So this is never a rescue drug for an acutely flaring patient. And up titrate gradually rather than starting at the target dose, which lets you catch toxicity early. Monitor blood counts and liver tests regularly while the patient is on it. Before you prescribe a thiopurine, there is a mandatory step. Check TPMT levels prior to dosing. TPMT is the enzyme that clears the drug. When its activity is low, toxic metabolites accumulate, and the patient can develop profound bone marrow suppression. The full complication list is bone marrow suppression, lymphoma, pancreatitis, and hepatitis. So monitor counts and liver tests on therapy. And one refinement worth knowing: in selected non-responders, adding allopurinol boosts thiopurine activity by shifting metabolism toward the active metabolite. That allopurinol combination is specialist territory. Do not initiate it unsupervised. Anti-tumor necrosis factor therapy also enters at moderate to severe disease. And here is an important trial finding. The remission rate rises when azathioprine is combined with infliximab, compared with either agent alone. So combination therapy is often the stronger choice. Among the agents, the efficacy order runs infliximab, then golimumab, then adalimumab. And there is one rare but serious signal to know: hepatosplenic T-cell lymphoma, described particularly in young men on combination therapy. Rare, but it belongs in the consent conversation. Check drug levels and antibodies if a patient loses response over time. Now the top rung: severe or refractory ulcerative colitis. Intravenous steroids to induce remission, and there are two accepted regimens: 100 milligrams of hydrocortisone intravenously every 8 hours, or 16 to 20 milligrams of methylprednisolone intravenously every 8 hours. Either one, every 8 hours. And exactly as before, they are given with a plan to taper and to switch to non-steroid maintenance. Say it once more because it is the single most common error in this topic. Steroids induce, they never maintain. If there is no meaningful response within about 3 days, escalate rather than continue. When a severe flare does not respond to steroids, cyclosporine is an option. It is given as an infusion at 2 to 4 milligrams per kilogram for 7 days. Understand what that 7 days is for. Cyclosporine is a bridge, not a destination. The goal stated explicitly is to change to a maintenance medication, for example, azathioprine or 6-mercaptopurine. So what those 7 days actually buy you is time. Time for a slow-acting thiopurine to begin working. If nothing is started underneath it, the bridge simply ends. Monitor renal function, blood pressure, and drug levels throughout the infusion. Anti-tumor necrosis factor agents also sit at this level: infliximab, adalimumab, and golimumab. They are used for steroid refractory flares, or to maintain remission once it is achieved. Now the complications you must screen for first: reactivation of tuberculosis, and the instruction is explicit: check a PPD prior to treatment. And reactivation of viral hepatitis, so screen hepatitis B as well. Both of those screens happen before the first dose, not after a complication appears. This is the most preventable harm in the entire topic. Also update routine vaccinations before starting. Live vaccines become contraindicated afterward. The rest of the anti-tumor necrosis factor risk profile. There is a small increase in the risk of non-Hodgkin lymphoma. There can be a lupus-like reaction. There is paradoxical psoriasis, where a drug used for immune disease triggers a skin condition. And there is demyelinating disease, multiple sclerosis, and congestive heart failure. Those last two are the ones most often forgotten at the point of prescribing. Anti-tumor necrosis factor agents can worsen existing heart failure, so take a cardiac history before you start one. Ask specifically about prior demyelinating symptoms and any cardiac history. Beyond anti-tumor necrosis factor, there is now a substantial list of newer agents, and the way to hold them is by mechanism class. Vedolizumab is an anti-integrin. It blocks alpha-4 beta-7. Tofacitinib and upadacitinib are Janus kinase inhibitors. Ustekinumab, risankizumab, guselkumab, and mirikizumab target interleukin 12 and 23. Ozanimod and etrasimod are sphingosine 1-phosphate receptor modulators. And fecal microbiota transplant remains investigational. Learn the classes. The individual names change every year. The mechanisms do not. Vedolizumab acts only in the gut, which is why it carries the least systemic immunosuppression. Now the Crohn disease ladder. Mild disease. Oral 5-ASA for colonic disease, with loperamide or cholestyramine for symptom control. Mild to moderate, oral budesonide, enteric-coated for ileal release. Moderate to severe, oral prednisone, a thiopurine, methotrexate at 15 to 25 milligrams weekly, and biologics. Severe or refractory, intravenous steroids, anti-tumor necrosis factor, anti-integrin, anti-interleukin 23, and Janus kinase inhibitors. And notice what is absent compared with ulcerative colitis. There is no cyclosporine rung here, and the biologic classes are the same. It is the sequencing that differs. Take mild Crohn disease first. Oral 5-ASA is used, but note the qualifier carefully, for colonic Crohn disease specifically. 5-ASA has a much smaller role in Crohn disease than it does in ulcerative colitis, and it does little for small bowel disease. Alongside that, we use symptom control, loperamide, or cholestyramine for diarrhea management. Cholestyramine is the interesting one. It binds bile acids, so it directly targets the bile acid diarrhea that follows ileal disease or ileal resection. Mechanism matched to the problem. Loperamide should be avoided in severe colitis. It can precipitate toxic megacolon. For mild to moderate Crohn disease, oral budesonide, enteric coated for ileal release, tapered over 3 months. Every part of that sentence is doing work. The enteric coating means the drug is not released until it reaches the ileum, which is exactly where the most common form of Crohn disease lives. The high first-pass metabolism limits systemic steroid effect, as we discussed with the colonic version, and the taper runs over 3 months, not 3 weeks. This is a slower withdrawal than most steroid tapers residents are used to writing. It is much better tolerated than prednisone, which is why it sits below it on the ladder. Moderate to severe Crohn disease, oral prednisone, same dosing as in ulcerative colitis, 40 to 60 milligrams, and the source is explicit, for inducing remission, not for maintenance. As a thiopurine and 6-mercaptopurine, same dosing as ulcerative colitis, 0.5 to 1 milligram per kilogram, and the same mandatory TPMT check beforehand. And the same combination finding applies here. Remission rates rise when azathioprine is combined with infliximab. The pattern is consistent across both diseases. The steroid gets them in. Something else has to keep them there. Bridge with a steroid while the thiopurine takes effect. Then withdraw the steroid. Methotrexate is the agent that appears in Crohn disease and not in ulcerative colitis. It is dosed at 15 to 25 milligrams, given intramuscularly, subcutaneously, or orally, once weekly. Note once weekly. Daily dosing of methotrexate is a serious prescribing error. Its role is maintenance of remission. And here's the timing you must communicate. It takes 1 to 2 months to take effect. So set that expectation with the patient at the start. A drug that needs 2 months to work cannot fairly be judged a failure at 2 weeks. Give folic acid alongside it. And check blood counts and liver tests. Biologics in moderate to severe Crohn disease. Among the anti-tumor necrosis factor agents, infliximab and adalimumab are preferred ahead of certolizumab. And you may consider combination therapy with azathioprine or 6-mercaptopurine. The same combination logic we saw in ulcerative colitis. Beyond anti-tumor necrosis factor, the options are revitalizumab, ustekinumab, risankizumab, and upadacitinib. Notice these are the same mechanism classes we listed for ulcerative colitis. The sequencing and the evidence differ between the diseases, but the pharmacology does not. Choose by fistulizing behavior, prior exposure, and comorbidity rather than by habit. Severe or refractory Crohn disease. Intravenous steroids, same as ulcerative colitis, for inducing remission and not maintenance. Anti-tumor necrosis factor, same agents as above. And here is a specific instruction to remember. It is first line when there is a perianal fistula. Then anti-integrin therapy with vedolizumab, anti-interleukin 23, with or without interleukin 12, and Janus kinase inhibitors, tofacitinib or upadacitinib, if anti-tumor necrosis factor therapy has failed. That perianal fistula rule moves anti-tumor necrosis factor straight to the front of the queue. Fistulizing disease also usually needs surgical assessment alongside the drug. Follow the 4 biologic classes across the screen. Anti-tumor necrosis factor agents neutralize tumor necrosis factor itself, the central inflammatory cytokine. Anti-integrin therapy blocks alpha-4 beta-7, which stops lymphocytes from homing into the gut wall in the first place. Anti-interleukin 12 and 23 therapy blocks the interleukin pathway that drives T-cell differentiation. And Janus kinase inhibitors block intracellular signaling downstream of many cytokines at once. 4 different points on one pathway. And that is precisely why failing one class does not predict failing the next. So a patient who fails anti-tumor necrosis factor may still respond well to vedolizumab. Now surgery. In ulcerative colitis, the indications for colectomy are symptoms refractory to medication, intolerable side effects from medication, colorectal cancer, perforation, toxic megacolon, and uncontrolled hemorrhage. Note that the list mixes elective and emergency indications. Refractory symptoms and drug intolerance are decisions made over months in clinic. Perforation and hemorrhage are decisions made in hours. The usual operation is a colectomy with an ileal pouch anal anastomosis, which preserves continence and avoids a permanent stoma. A pouch is not possible in every patient. Age and sphincter function both matter. Surgery in Crohn disease is a different proposition. Resection is used when disease is refractory to medical therapy. Surgery is used for strictures, which are fibrotic and will not respond to any amount of immunosuppression. and a diverting ileostomy is used for perineal disease. Now here is the governing principle. Resect as little as possible. Crohn disease recurs, so a patient may face repeated operations across a lifetime, and each resection removes more absorptive surface. Enough resections and you produce short bowel syndrome, which is its own serious disease. Stricturoplasty preserves length where the anatomy allows it. Hold these two side by side because they are genuinely different. In ulcerative colitis, colectomy cures the colitis. The disease lives only in the colon, so removing the colon removes the disease. Pouchitis remains a possibility afterward, but the colitis itself is finished. In Crohn disease, surgery is not curative. The disease characteristically recurs at the anastomosis, because Crohn disease can arise anywhere from mouth to anus, and you cannot resect all of it. So never tell a patient with Crohn disease that an operation will end their disease. It will not. Post-operative prophylaxis is started precisely because recurrence is expected. Now, cancer risk. In ulcerative colitis, the risk of colon cancer runs at about 2% at 10 years from diagnosis, about 8% at 20 years, and about 18% at 30 years. Notice the shape of that curve. It is not linear. The risk accelerates with duration. The figures are similar for pancolonic Crohn disease, and Crohn disease adds a risk of small bowel cancer that ulcerative colitis does not carry. Those three numbers are worth memorizing. They are what justify a surveillance program to a patient who feels perfectly well. Those numbers are for the colon. Small bowel cancer in Crohn disease is separate. Several factors raise that risk further. Dysplasia is the single best marker of risk, which is precisely why surveillance biopsies look for dysplasia rather than for cancer. Primary sclerosing cholangitis raises risk. A positive family history raises risk. Greater extent of disease raises risk. So pancolitis carries more risk than proctitis. And stricture and pseudopolyps raise risk. That last pair is worth pausing on. A stricture or a field of pseudopolyps is not merely old scarring. It is a red flag that shortens the surveillance interval. Reassess the risk factor list at every surveillance visit. It changes over time. So when does surveillance begin? Colonoscopy with random biopsies 8 years after diagnosis. And the purpose is stated explicitly to evaluate for dysplasia, not to find cancer, to find the change that precedes it. After that first examination, the interval is every 1 to 3 years, and where you sit in that range is decided by the risk factors we just listed. A patient with pancolitis and primary sclerosing cholangitis sits at the 1-year end. A patient with limited proctitis and no other risk factors sits at 3. Document the 8-year date in the chart at diagnosis. That is how it stops being missed. One refinement to the technique. Chromoendoscopy uses a dye sprayed onto the mucosa to stain high-risk lesions, so that biopsies can be targeted rather than random. And the source notes it may be preferable to random biopsy alone. Here is why that matters. Dysplasia in inflammatory bowel disease is frequently flat and subtle. It does not present as an obvious polyp, so random biopsies can genuinely miss it by sampling the wrong square centimeter. Staining the mucosa makes those flat lesions visible so the biopsy goes where the abnormality actually is. It requires training and adds time, which is why uptake varies between centers. And what changes the plan? If surveillance finds high-grade dysplasia, or a dysplasia-associated lesion or mass, the answer is colectomy. That is a surgical finding. It is not a reason to repeat the colonoscopy in 6 months and hope. The reason is the risk of synchronous cancer elsewhere in the colon, where there is high-grade dysplasia in one area. Invasive cancer is frequently already present somewhere else that was not sampled. So refer for colectomy rather than observing. This is the point where surveillance stops being surveillance and becomes treatment. Low-grade dysplasia is more debatable and belongs in a specialist discussion. The pitfalls that cost patients. First, starting a biologic without screening for tuberculosis and hepatitis B, the single most preventable harm here. Second, dosing a thiopurine without checking TPMT first. Third, using a steroid as maintenance therapy. Fourth, judging methotrexate failure at 2 weeks when it needs 1 to 2 months. Fifth, treating symptom resolution as if it were mucosal healing. And sixth, letting the 8-year surveillance clock pass unnoticed because the patient has been well. Being well is exactly when that clock is easiest to miss. Every one of those 6 is preventable with a checklist. Back to our 2 patients. The woman with left-sided moderately to severely active ulcerative colitis. We induce with oral 5-ASA plus a steroid. Then for maintenance, we move to a thiopurine or an anti-tumor necrosis factor agent, after checking TPMT and screening for tuberculosis and hepatitis B. The man with ileocolonic Crohn disease and a perianal fistula. His perianal disease moves anti-tumor necrosis factor to first line, we consider combining it with a thiopurine, and his 8-year surveillance clock starts from today's diagnosis date. Both also get vaccination review and bone health assessment before immunosuppression. Let us bring it together. Exclude the mimics and rule out infection before any immunosuppression. Induce remission, then maintain it, usually with a different drug. Mucosal healing is the goal. Symptom resolution is not enough. The ulcerative colitis ladder runs rectal therapy, oral 5-ASA, prednisone and a thiopurine, then intravenous steroids, cyclosporine and biologics. The Crohn ladder runs 5-ASA, budesonide, prednisone, thiopurine, and methotrexate, then biologics. Check TPMT before a thiopurine screen before anti-tumor necrosis factor, and start surveillance at 8 years. And consider an early biologic in severe disease rather than climbing the whole ladder. These are the sources behind today's material. The medical therapy tables follow the New England Journal Review of Medical Therapy for inflammatory bowel disease. The overall management framework follows the Lancet Review and the Mayo Clinic Proceedings Review. The ulcerative colitis regimens follow the American Journal of Gastroenterology and Gastroenterology. The Crohn disease regimens follow JAMA and Gastroenterology. And the cancer screening protocol follows the New England Journal. Thanks for working through this one. It is a dense topic and you got through it. See you on the next video. The 2 disease videos in this series cover recognition and diagnosis.